Ladies and gentlemen, now let's start. More serious issues. More serious issues. We'll look at orbital diseases. I think in terms of the anatomy, there is the bony orbit, which you know is there. And inside the bony orbit protects the eyeball. So we've got the sockets, right and left, for those who haven't lost a single eye as yet. So we'll look at the diseases that affect the orbit. This one, huh? That's what I'm saying. What happened? We'll start with a condition called preceptocellulitis. Preceptocellulitis, if you look at the anatomy, which is not here, there is a septum separating the outer side and the inner side of the orbit, a fibrous septum. So when you say preceptor, it means the inflammation or the infection is anterior to the septum. Infection of the subcutaneous tissues anterior to the orbital septum. Okay, this definition. Preceptor means it's anterior to the septum, the orbital septum, that fibrous tissue. While orbital cellulitis is one behind that fibrous tissue. Causes of preceptocellulitis: skin trauma, lacerations or insect bites. Among the insect bites are the bees, those that want honey, which they never make, but they just want to collect. The insects which make the honey, they have to defend their stuff. Organisms involved are usually Staphylococcus aureus, Staphylococcus pyogenes, and also you can have spread of local infection. You got some infection on the skin, it can spread to preceptocellulitis. Or you can have an injury on the upper eyelid, a small cut there, which gets infected, then the whole preceptor area gets inflamed. Spread from acute odurum, dacryocystitis, sinusitis, all these can ultimately lead to preceptocellulitis. But what is important is this definition that preceptor is anterior to the orbital septum. There is a fibrous tissue which separates the outside and the inside of the orbit. So when it's preceptor, it's anterior. When it's septor or orbital cellulitis, it's posterior. Sometimes from preceptor can end up into orbital. So you have all the areas now inflamed. Sometimes you have spread from some remote infections like respiratory tract, middle ear infections, or a blood spread. All these things can be a cause. Clinical signs usually is unilateral, tender, and red lead with periorbital edema. Proptosis and ecchymosis are absent. What is proptosis? Proptosis is protrusion of the eyeball going forward. That's proptosis. Ecchymosis, swelling of the conjunctiva with fluid. So that is absent. Ecchymosis is absent, but proptosis is there. The visual acuity, pupillary reactions, and ocular motility are normal because this infection hasn't gone into the eyeball. And you know from what we were learning yesterday, you know that the the cells which get the light from the in the retinal cells, isn't it? So you can see retinal cells inside in the retina in the eyeball and where the preceptor is. So there should be no pupillary abnormality. If there is, it's more than the preceptor cellulitis. There's also something then inside. CT scan shows the opacification of the anterior to the orbital septum. Here is a good picture. Preceptor cellulitis, all this lid margin and around there, it's all swollen. But the infection is anterior to the orbital septum. Posterior to the orbital septum is normal. Preceptor cellulitis, CT scan, you can see normal. This is the optic nerve. These are muscles, medial rectors, lateral rectors. This is the eyeball. This is the lens, the white stuff with lens. This is the normal side. Okay. When you go to the other side, inside there, behind the eyeball, this is the muscle. This is the optic nerve. This is muscle, and this is the eyeball. This white stuff there is the lens. So the swelling is in front there, because the septum covers there up to there. So preceptor is there. If it was orbital, it should be here inside. So left preceptor cellulitis. Actual CT shows the opacification anterior to the orbital septum. This is the orbital septum. This anterior is there. Well, this side, there's nothing. Okay? Apple. Huh? Oh, you want to? Okay. We can continue. Okay. So orbital cellulitis would be here. There would be obviously compression of the optic nerve, and the orbital movement of the eyeball will be affected. These muscles will be inflamed. But preceptor is there, outside the orbital septum. Treatment, amoxiclav, any strong antibiotic you can give. Amoxiclav must be amoxicillin, 500 or 125 milligrams, 8 hourly. Severe cases may require IV treatment. What are the severe cases? It's up to you. The attending clinician can see that this patient is more sick. For example, a case which has been sitting there for a long time before coming, you are not sure whether it's still preceptor or it's in the stage where it's now involving the orbit itself. Bacterial, this is a variety of the cellulitis. Bacterial orbital cellulitis is infection of the soft tissues behind the orbital septum. Preceptor is anterior to the orbital septum. Orbital is posterior to the orbital septum. So in this one, the bacterial orbital cellulitis is infection of the soft tissues behind the orbit. It will be here, behind here. The orbit is there. The orbit is that's there. These are bone orbit there. Preceptor is outside there, but the orbital one is here inside. There. So definition of orbital cellulitis is infection of the soft tissues behind the orbital septum, while preceptor is in front of the orbital septum. Occurs at any age but it's more common in children. This is a life-threatening infection. Common causative organisms are the bacteria like Streptococcus pneumonia, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenza. All these are bacteria which can cause that. Pathogenesis, how does the disease arise? One can be sinus related, most commonly ethmoid sinuses, typically affecting children and young adults. Extension, you can have extension of preceptocellulitis through the orbital septum, then it goes and becomes, from preceptor, it becomes septal. So you can have extension. But this one in extension, where there is extension, the clinical picture is clear. Started as a swollen, the swelling was in the front, but then once the inside gets affected, it disturbs the ocular motility, the muscles which are in the orbit, in the actual orbit. It's one of the most important. There will be compression of the optic nerve as well, signs of compression. So extension of preceptocellulitis through the orbital septum, which we call the local spread, from adjacent dacryocystitis, so you can have local spread from adjacent dacryocystitis or from midfacial or dental infection. All these things can ultimately be a source of the infection for the orbital cellulitis. You can have hematogenous. Hematogenous, this is spread through the bloodstream. It is referred to as hematogenous. Post-traumatic, after a good fight, whether it's good or not, there's somehow a loser. And you can have causes of that infection or the orbital cellulitis coming from this trauma. And this will develop within 72 hours of an injury that penetrates the orbital septum. Basically, it means infection from outside has finally been transmitted into the orbit. Post-surgical may complicate retinal, lacrimal, or orbital surgery. What is that? Oh. Yeah, that's the one. When they say post-surgical, there will be post-surgical, for example, if you're trying to muscle surgery to align the muscles, or you are going for retina, you get infection coming all over here. So anything. But what is important is you will know, the patient will know that things are not okay. And it's the things which preceded that infection which gives you a possible cause. Trauma, straightforward story, they were fighting. Usually the one who has the problem was the one who was speaking loudest. We're here. Yeah, okay. Presentation, you have rapid onset of severe malaise, fever, pain, and visual impairment. Visual impairment is basically infection now is actually in the orbit. You know, there will be compression of muscles, there will be compression of the optic nerve. That's why you have that visual impairment. You know? Pain, compression, fever, because it's an infection which is there. You know, Clinical signs, there will be unilateral, tender, warm, and red periorbital and lid edema. This only occurs if the other eye is intact. If both are affected, both eyes will have the same problem. Although this event, if you say traumatic, it's unlikely that you can have a good bash on this side. The other guy also comes to sort out the other eye for you. Usually it's unilateral where people were fighting. You have unilateral, tender, warm, and red periorbital. And when you check the periorbital area, it's tender and warm because of the infection inside. This will be swollen up. Proptosis will be there. Proptosis is protrusion of the eyeball forward. Because of the infection behind, there is pus accumulating, which will push the eyeball forward. Eye movements will be very difficult. It's not full because of the presence of pus there. Patient may just manage to move a bit, but full eye movement will not be there because infection now is attacking, is affecting the muscles, the extraocular muscles, which are also within that orbit. Optic, where are we? See here. Painful ophthalmoplegia. Painful ophthalmoplegia means when the patient is trying to move the eyes, it's painful. Yes, it's painful because these muscles are literally in pus. When there's infection behind the eyeball, those extraocular muscles, lateral, medial, whatever, they are all affected. They are inflamed. So any eye movement, you have that pain. Ophthalmoplegia is pain on moving the eye, the movement of the eyes, because the muscles themselves are also inflamed. Painful ocular motility. This is the same thing. When moving there, you have that pain. Look up, look down. The person is staying there. It's very painful. Optic nerve dysfunction because of the compression of the optic nerve. Pupillary reactions are abnormal. Why? Anyone with an answer? Less than a minute. Let's have another. We'll continue today.